Dr. Gee and esteemed colleagues, today we are here to discuss a very troubling problem that affects the very core of maternal and child health here in the state of Louisiana: preterm birth and infant mortality. The March of Dimes recently issued their annual rankings of where each state stands with how it has done in improving the health of babies by eliminating or preventing birth defects, premature births, and infant mortality. Louisiana has received a grade of F for having a rate of 15% of babies born prematurely. Premature birth is defined as birth prior to 37 weeks gestation. The national rate is 11.5%. Additionally, Louisiana has an infant mortality rate of 8.9 deaths out of every 1,000 live births, the second highest in the country. Research shows that this public health issue disproportionately affects women and children at the lower socioeconomic status levels. It should be the goal of the state to overcome the health issues associated with poverty that are directly impacting the health and future of the state's population. Overcoming poverty will directly affect the health outcomes of pregnant mothers and newborns, decrease the costs associated with poor health at birth, and reduce the preterm birth and infant mortality rates. While individual organization efforts can chip away at the larger issue, it takes the coordinated efforts of well-thought-out and implemented policy to make significant headway into reducing the preterm birth and infant mortality rates. Using the socio-ecological model, we can identify those areas that can be improved upon from the individual level through the policy level. While we've made improvements from a public health perspective on improving the overall knowledge base on pregnancy, the good and the bad, medical advice, nutrition, and more for mothers in the medical community, there are still areas where significant improvement can be made at the organizational, community, and policy levels. These are the areas we will discuss here today. These three levels represent the areas that I hope will be addressed through the interventions that will be presented on today. Essentially, what we can do from a policy standpoint. Research shows us that poverty, lack of access to quality services, and the care and correlation between preterm birth and later poor health outcomes can be directly impacted by instituting policies to address the barriers caused by poverty. These areas hold the largest potential for change in establishing a better health outcome for pregnant mothers and newborns. As a public health priority, the state should take action through policy to ensure a healthy population. At the organizational level, interventions and practices can be disseminated down, spreading out to affect not only how people live, but how they can improve their situations. The same is true for the policy level, which can provide massive impact by guiding medical, clinical, and public health officials, as well as families, on better health practices. Our policy analyst group has monitored the research on several areas very closely, and we have developed 3 ideas based on evidence-based practices to address the preterm and infant mortality issues in Louisiana. The first would standardize the neonatal clinical practices across all medical and clinical settings. Implementing this standard through the creation of a care manual and the financial means to fully educate and bring all healthcare facilities to the same high level would provide the same quality standard of care for all women, regardless of socioeconomic status. This would address the organizational level by reducing the barriers of programs like Medicare and Medicaid and poverty. The second would work to stabilize the financial inequality of maternal care by working with medical, public health, government, and non-governmental organizations by creating a healthy and reduced stress atmosphere for mothers to live and work in. This addresses the community level by helping to create a community-based support system. Finally, research has shown that unintended pregnancies are strongly correlated to increased risk of preterm birth. To address that area, we recommend that the access to family planning services be expanded and costs associated with those services be reduced. Providing these types of services for women who may not be able to access these services normally would reduce the amount of unintended pregnancies, which in turn would reduce the amount of preterm and infant mortality rates. This would address the policy level by strengthening the ability of women to access family planning services by increasing the commitment of the government to healthy families. To determine the success of these evidence-based practices once implemented, it will be important to review data covering several aspects. Both the antenatal care packages and the standardization of neonatal clinical care can be evaluated using similar data sets. For instance, the creation of a retrospective cohort study using data from PRAMs could be used for both, cutting down on costs associated with reviewing this data. The creation of a prospective cohort study would be necessary to develop comparative data to see any improvements. This data would also be supplemented by tracking the training of medical and clinical staff in relation to the neonatal care, with surveys being conducted on previous knowledge and practices compared to knowledge and practices after the training is completed. In addition to the retrospective and prospective cohort studies and PRAMS data, data regarding the distribution of antenatal care packages will need to be tracked and provided by the local health agencies that will be responsible for coordinating the services between medical, public health, and non-governmental organizations involved. Careful tracking of this will be necessary to provide accurate numbers for comparison to the cohort studies. For the third intervention, current numbers regarding the rates of usage for services and the individual types of services used will be needed to gather and be gathered by current family planning service centers. A retrospective study of women will be created to survey those women that had preterm births and how many pregnancies from those preterm births were unintentional. This data will be supplemented by PRAMS data as well. After access is increased, usage data will be collected from those facilities and the new ones to determine if the amount of usage has increased and how it has changed. This data can then be compared to any changes in the preterm birth rates. In attempting to implement these new policies, there are certainly some challenges and barriers that will need to be overcome. Primarily, there will be the challenge of funding. Ensuring the necessary amount of funding for each of these proposals is critical to their success. Lawmakers and taxpayers will take issue with the amount of money being spent. However, it will be important to stem those concerns with an informational campaign outlining the cost-benefit analysis showing that money spent on proactive solutions is cheaper than money spent on reactive solutions in healthcare issues. Additionally, some of the overall cost and resources can be offset with cooperation from medical, clinical, public health, government, and non-governmental organizations. Coordinations with these groups can spread the cost around, while additional coordination efforts with nonprofits can centralize their efforts towards the state's goal of reducing preterm and infant mortality rates. The collection of data, both pre-implementation and post-implementation, is difficult to gather. Data provided by clinical and non-clinical service areas will need to be well coordinated and gathered in order to ensure accuracy of outcome data. This can be done by clarifying the data needed to the sources provided by them. Additional work will need to be done to make sure that the follow-up data from the prospective cohorts is both accurate and complete. Tying this data to the post-birth follow-up appointments to 1 year will help overcome this problem. It will require cooperation from medical personnel, but should not add enough to overburden those resources. Implementing these policies will take the cooperation of medical and clinical personnel, nonprofits, and public health officials. Coordination of efforts from start to finish will result in better health outcomes for the mother and child overall, while reducing the preterm and infant mortality rates, which is the primary goal of these policies. I hope that you will seriously contemplate implementing the policies we have discussed here. I want to thank you for your time and consideration today.